do not have a quorum, so I'd like to call this meeting to order. It is nice to be here in person this time rather than have my disembodied voice through the phone. And it's also exciting to be here. I think we're a pretty diverse body here with a common goal, which is to preserve high quality and equitable access to medical marijuana for patients in the medical marijuana program, and also advance research and clinical care. And I think as a physician and as a researcher, there's nothing that highlights our knowledge deficiencies more than increasing the access. So I think those things go hand in hand. So just to start with, let me go around the table really quickly with introductions, your name and affiliation, and then we'll dive into the agenda.
I'm Jesse Sweet. I'm the representative from OLCC.
I'm Anthony Taylor, patient representative.
Please try to turn your microphone.
Oh, I am.
Katrina Hepburn, State Health Officer with Public Health. Dr. Rachel Knox, attending physician.
Esther Chu, physician and researcher from OHS.
Shannon O'Fallon with the Oregon Department of Justice.
Carol Yan, the Oregon Medical Marijuana Program. Margaret Flershinger, also with the Oregon Medical Marijuana Program, supporting that mission. Okay, first order of business is to review and approve documents from the first meeting, and I trust that the members of the commission have had a chance to look at this before stepping into the room.
There's a sign on the door.
So the first document is the minutes from the previous meeting, and those were distributed to us by Carol, and I think are in this packet.
They're in the meeting materials.
I see there's a tab called meeting minutes. I presume that's.
Materials. No, all the meeting materials for this meeting are.
Oh, I see. They're under the green tab, meeting materials. The first document.
Need a minute, or have you already reviewed them?
Do you need a minute, or have you already reviewed them? You're good.
Andre Russo, Administrator for Center for Health Protection with the Oregon Health Authority.
Chair Chu, are you looking for a motion?
I will make a motion. I'm just making sure everyone's had a chance to flip through the minutes if they need it. Once I get eyes up, I'd appreciate the motion. I'm getting eyes up. Should I make a motion to approve the minutes? Do I hear a second? Anyone in opposition? I think we've approved the minutes. The second document is the revised bylaws. And again, if you'd like to take a minute to review, and then when eyes are up, I'll make a motion.
That's also there in that same section.
I'm sorry.
Same section.
I do have one comment. This is Anthony Taylor. I do have one comment on the bylaws before we move to accept them. And page 3, sub 4, duties and responsibilities of a member. A, in the course of conducting OCC business, a member is expected to work in furtherance of health and safety rather than the interest of any profession, institution, or individual. I would like to amend that to read furtherance of stated mission and goals rather than the interest of any professional, institution, or individual.
In place of, not.
In place. Yes, Madam Chair, in place of. I mean, I'm totally happy to work the health and safety in there also, but I think it's more important to concentrate on the mission and stated goal of the commission rather than just health and safety.
I'm sorry, can you read the whole sentence as you would have it read?
Yes, in the course of conducting OCC business, a member is expected to work in furtherance of the stated mission and goals of the Oregon Cannabis Commission rather than the interest of any profession, institution, or individual.
Any further comments on that?
This is Katrina. I do have a question about what are the specific goals listed somewhere? Are you talking about two, what the OCC shall provide advice, do this, etc.? Because again, if it's in furtherance of the goals, then we've got to be sure that we have the very specific goals articulated. And I'm assuming it is on page 1, under Article 2.2, the roles and responsibilities, but it doesn't quite say goal of the commission.
So should we say in furtherance of the stated role and responsibilities of the OCC?
So that would be okay with me.
I second that. That was
Wasn't it for a motion? Any other, should we make a motion to accept that specific thing and then the bylaws as a whole? Okay, so I think I second Andre's motion. All in favor? Aye.
Aye.
Any other changes?
I have a language suggestion under, sorry, smart microphone. So it's going to be on page 2 under Article 2, about middle of the page before Article 3, determining the possible framework for the future governance of the OMP as set out above. The OCC shall consider the last bullet point, just for consistency in language and grammar. It should be building upon or to build upon and not build upon. So shall consider is the first clause of the sentence, and then you list 4 other clauses, so they should just match up language-wise. So it should read, it would read better if it says the OCC shall consider building upon current science and research and reports created by the Public Health Division pertaining to cannabis.
I feel like to be consistent should just read current science, start with current science.
Sure.
There are no other gerunds, you know.
Sure, yes.
Are we only going to accept reports created by the Public Health Division?
This is Katrina. I think you just need a comma. Current science is current science. Research is research. And reports. Oh, I understand your point. So it's reports created both by public health and others pertaining to cannabis. So do we need the public health division in there as your point?
How about just,
Have it just strike created by the Public Health Division. I think if we leave it more open, it will include reports created by the Health Division and others. So that bullet point will read current science and research and reports pertaining to cannabis.
If I'm not, I'm trying to remember back to last meeting. But part of this was that I had volunteered that we didn't want to recreate the wheel. So last session or 2, I can't remember, but the legislature had assigned to us the responsibility of doing a task force on the medical and public health properties of cannabis. That was House Bill 844, and we produced a report. And so I didn't want this committee to recreate a report that had already been created. So the purpose of that was actually pretty specific. So I don't know whether we need it or not. I just wanted to be sure that we reviewed work that had already been done in response, again, to legislative intent, specific to Oregon, as opposed to review. Because I'm sure there are dozens, if not thousands, of reports related to cannabis. And so it was really, the science and research is general. The report was a very specific task that we had been assigned by the legislature to do.
Madam Chair. Okay. I think it's all inclusive, Katrina. I think.
Am I hearing a motion to accept that amended wording that is more open?
So moved.
Any opposed? I meant like any opposed rather than hearing a multitude of ayes. Is that okay? Any opposed? Okay. Any other, sort of last chance for any other wording changes to our bylaws?
Madam Chair, just, we now have an updated version of the Oregon statutes that include legislation passed them through the first part of 2017. So I would just maybe say, as we're finalizing the bylaws, if we can replace Oregon law references to statutory numbers, it might make for an easier read for people to more easily find the statutes. I don't have them at my fingertips, but we can just sort of do that housekeeping as we finalize, if that's okay with the commission.
Makes sense. Okay, with that caveat, I'd like to make a motion to approve the bylaws.
I'll second it.
Any opposed? Okay, motion passed. And finally, the commission, the last document is the commission report. This was, do we need to approve those or? No, okay. That's already been submitted.
So the legislature is looking at extending the time on the reports, and will actually have time to put a real report together. So the proposal at this time is through December 31st of 2018, which will give you guys time to actually have something of substance.
I'd like to expand a little bit on that point with the proposed legislation. We, as a commission, essentially have two functions. One is to report to the legislature, and the other is to advise the agencies. The current statutory language has our authority to make legislative recommendations expiring in, I believe, July. Is that correct, Carol? So there will be legislation presented that will extend that portion of our mission statement. So it's not only the due date of the report, but it's also, our authority to make the report at all needs to be extended in order to give us enough time to do that.
And to further add to that further is that that particular section is also the one that allows us to make legislative proposals. So this gives us the rest of the year to come up with what most people are looking for, a comprehensive bill to come out of this commission.
When will we know?
We will know
March 10th.
March 10th at the latest. This,
Not later than.
yeah, the short session begins next week, and the bills will move pretty quickly through the committees. So we should have, by the next time we meet, a better sense of where this bill is going.
Okay,
So should we move right into the next section? This will be starting kind of the meat of the meeting. So I wanted to just start, so this is really the beginning of this commission's work. I wanted to start with a solid hour of just open discussion of what we hope to accomplish. And I know that we already mentioned that the scope of this commission is very broad and ambitious. And I guess in my emergency medicine fashion, I would like to really focus on the highest priority, most feasible things that we can do, just so that we know what to sink our teeth into and we can actually try to make progress in a concentrated fashion over the first year of our body. So I'm okay if this hour does wander a little bit into into idealism, but I would like as much as possible before we leave the room today. I feel like I'm not doing well with this mic. Before we leave this room today, to really have an idea of what our highest priorities are and what our action items are before we convene again. Does that seem fair? All right, so I think Anthony will start with you, and after that we can go in any order, but I know you made an offer to sort of spend 10 minutes anchoring the group in the history of this commission and just kind of your background coming into this. We will be keeping an eye on the clock. I think probably my main task as a chair is to keep us on schedule and moving forward. But let's start with you, and then I'd like each member of the commission to address my question. And then the last 15 minutes of this is more public commentary. We wanted to bring that up to the top of the meeting so that people weren't waiting around kind of board of color administrative tasks and not have a chance to speak until the very end when people are streaming out of the room. Somebody's going to help me keep, yes. I have a time, okay, so we'll have a scribe up here. We will be keeping track of all comments. These big sticky pads will go up on the wall, and then the next part of the meeting will actually be a little bit more fine-tuning and having everybody on the commission have a chance to weigh in and see what their priorities are. So can I turn the mic over to you, Anthony?
Well, thank you, Madam Chair. I just want to start by saying how pleased and fortunate I feel to be serving on this commission. And under the leadership of you, Madam Chair, and Madam Vice Chair, I think we're going to accomplish a lot of stuff here and be able to provide a forum for not just us, but the community, not just us and the agencies, but the communities that speak about issues that are important to patients. I also want to say that there's been a long history of OHA and disgruntled patients and all that sort of stuff, but over the last couple of years, the OMNP, their staff, Andre, Carol, Chris Westfall, Margaret, everybody has just done an exceptional job in the last couple of years. They've reduced cart turnaround times from months to days. They created the online application system, which was long overdue. They dealt with the OHA reporting system and created that rather than just going and buying it off the shelf. And there's still, of course, there's always, work in progress on some of this stuff, but, not to fail to mention the achievements of the last couple of years, I think would be a disservice to the people that did that. So historically, the program started under DHS and then, of course, now OHA, but typically pretty unresponsive to patient needs, especially in the first 10 years. And somewhat of a disinterest in the program and just kind of let it simmer on the back burner until, the squeaky wheel comes out, and then we'll oil it if we have to. So out of this frustration and out of frustration of having to wait 2 or 3 months to get a card renewed or a new card issued, we decided that perhaps we should find a better way and create a board or a commission, some sort of body that would take over the stewardship of the medical marijuana program and improve it, streamline it, do what we need to increase patient services, to make sure that the patients were being treated fairly by their growers, and other issues of both accessibility and affordability, but more important was the issues facing the patients as patients. Having THC in your system when you go to get treatment other than your conditions, those sorts of things. Pain management contracts, doctors that won't prescribe certain medications for cannabis patients just because they're cannabis patients. All these sorts of issues kind of came to a head, and so in the summer of 2016 I began working within Representative Buckley's office to create a bill that would create an Oregon Cannabis Commission. Originally it started out as the Oregon Medical Use of Cannabis Board. But then Senator Ferrioli had introduced Senate Bill 300, which established a Cannabis Commission. So we took some of that and we took some of what was in the original 2198 and put them together and created this commission, a 9-member commission. And so here we are, here we find ourselves. I think we have a lot of stuff to do. But before I go there, just another. So what we just tried to do with this bill was place the job of direct oversight of the program in a board or commission. And that board would be appointed by the governor, report back to the legislature, and give some sense of responsibility, accountability, I mean to say, for this program. Then improve, streamline, and expand the program through legislation, public awareness, outreach, and education. Integrate cannabis into mainstream medicine and eliminate discrimination based solely on the use of cannabis. Create the necessary educational training for physicians and healthcare professionals, and fund and direct research. And so while it's hard to get all that intent into legislation, we got the Cannabis Commission created, we've been appointed, nominated, and confirmed, and so here we are today, and I really look forward to the work that this commission is going to do and being a part of that, and look to be as strong a member of that team as I can be. Thank you very much. Oh, just one more thing. I also had some of the things that I thought might be important printed up and for everybody to take a look at and pick and choose and prioritize, add to it, edit it, however they feel. Thank you very much.
Anthony, are these your priorities that you want me to put up for recommendation?
Yes.
Okay.
And I kind of prioritized them myself, but I'm not the know-all be-all guy on this sort of stuff. And then on the back side, I put some housekeeping questions like, what's our budget? How's the budget look? What's the revenue coming in? All those sorts of housekeeping things that I think we need answered because, you know, prior to this last session, the fees generated by this program were funding 6 other non-marijuana programs in the OHA. That funding has now been is now being taken out of the general fund, so I'm just kind of interested in seeing where we are, and because I really think it's important that this commission creates some way to provide more revenue for research other than just the fees, whether it's and you know to consider outside sourcing and things like that. So thank you.
And for this, if you don't mind, I'm just going to put this.
I think there's plenty of room for dots, yeah.
Yeah.
Thank you, Anthony. It's not a door with you. I'm just, do you want to go? Okay, I was kind of, my default is to look at Jesse for some reason. Voluntary. So just to reiterate the question, I just wanted to go over the room and have each member of the commission talk about what they feel like are the priority action items for this commission this year.
So something that Anthony brought up last meeting that I actually feel very strongly about is doing a public hearing tour around the state so that we can get a really strong sense of the needs and concerns of patients and their growers, et cetera, while we're trying to formulate recommendations to our legislators. It sounds like we might be able to mobilize resources to do that, and we'll talk a bit about that at the end today. But I think that's a top priority because we are serving the public at large. We need to be able to hear and spend time listening. So these sessions would not be us talking, it would be us purely listening to the needs of our communities.
Just, thank you.
You know, with the question being, what should we prioritize first, I think a more technical view of it, and I start reading the statute and looking at what's in there. Section 4 of 2198 was the section that I referred to previously, which is set to expire. So that's where my mind naturally goes for priorities. Within that section, there's essentially 2 large subsections. One is proper oversight and regulation of the program, and the other is having to do with ensuring research on cannabis is facilitated. I think, as Dr. Heckler has mentioned, we already have a pretty good report on research. I personally have some questions about the funding aspect of that report and its feasibility, but the work has been done, which naturally leads me to proper oversight and regulation of the system. And there's a lot of words here. I think different words will attract different members of this commission depending on our context. You know, I tend to focus on proper oversight and regulation. That's my context, but there's also a lot of language in there about ensuring patient access. And I think that's really been the challenge that the legislature has been dealing with, frankly, for the past 3 sessions, is how do you curb some of the abuses in the program that we all know are there, while simultaneously ensuring that people who need access to this medicine still have access to it. That's what they've been struggling with, and frankly, they haven't found a real good answer. And I think that's our task here as the commission. I think that's our primary task, and it's a pretty big one.
Yes, so thank you very much. I would echo, I think both of you have talked to Anthony's comments here around directing research and or funding research. I do think there's a lot that we don't know, but I think we have a good idea. We sort of know what we don't know or what the issues are, and so I don't want to rehash that. I do think that Senate Bill 844, a big component of that was how do we develop funding. We know other states, California has a Cannabis Institute. I know Colorado had some funds set aside so that their public health department would have I'll say mini grants, although I don't know how many they were. They might have been on the order of $1 million or something, but funds set aside to research some very distinct aspects of it, and I think that would help support Oregon. So I wanted to say that certainly for me is one priority, not reinventing the wheel, but figuring out how to move forward. The other piece that I think, from my perspective, is important is that for cannabis to be, how to put this, more recognized as, I don't know if the word is more recognized, but we certainly know that there are constituents within the medical community and other places who don't recognize cannabis as being a medication or an appropriate medication. That part of the way to gain some legitimacy, if that's the right word, is to have both guidelines, and we now have guidelines for how you evaluate patients, document, etc., but it's still for recommending cannabis. And I would agree that, for example, development of protocols for dosing and treatment options, so again, that's right in the middle of the page, but right now there aren't any guidelines, and so for something, again, being trained as an allopathic physician, we have very clear what are the dose, what's the response to treatment, what are potential side effects, how might those be alleviated, and so again, to be able to evaluate. We know the reasons that hasn't happened so much because of the constraints at the federal level and the Schedule I substance, etc. I'm not sure that that's going to get better in the short term, I'll just put it that way, but nonetheless, I think it's still important for a state like Oregon and the other states that do have medical programs to start to think about how do we approach this in a way that, again, is objective, thoughtful, etc., in terms of both evaluation, what's the treatment, what's the dose, what's the response, what are side effects, just the same way that we evaluate other therapies.
Just to echo her comments, I really think that dosing and frequency is probably one of the biggest issues that face both patients and physicians right now, and probably right up there, even though it's in the middle of the list, probably right up there near the top of it, in combination with the other stuff that we need to really make sure that our physicians are knowledgeable and protected.
Thanks. This is Andre. I would echo Katrina's thoughts. I think that's an important step into bringing cannabis into a more legitimate light in the medical profession. I think many of the questions and concerns I have from practitioners is that I don't know what my patient takes, I don't know how much, and I don't know route of entry. And I think that there are some resources out there, and I think that the OMMP and OHA can at first, begin guiding people to these resources, or at least make them available. So I think that would be one of my goals for this year. And my second goal, which many people here are already aware of, is that I would like to ensure integrity of the product. And I think that we do that through a comprehensive testing scheme. And I think what's missing right now from the state is a random testing scheme to make sure that laboratories are indeed testing the products appropriately and not merely testing them to gain more customers and clients, and that growers and processors are aware that they have a responsibility to produce a reasonably safe product and to kind of step into the culture that is out there with other agricultural products and other drug products that, the product says what it is. So I think that testing and developing a random testing scheme would be my top priority for this year.
Wanted to add a few things. I was wondering, I know that every state that has legalized cannabis for recreational use is struggling with this problem, which is access and affordability of medical marijuana patients. And from what I can tell, they're all pretty much just letting the numbers, the enrollment in the medical marijuana program just plummet. It's been very dramatic in Colorado. And I haven't really read a lot of the narratives, but there's a lot of narratives behind those numbers. Nevada is the only one that I've seen talk about this in a really proactive manner, and maybe I'm just missing it and you guys know. They're talking a lot about how they can sort of restructure the taxes around the recreational cannabis program so they can sort of bring that back to the medical marijuana program and actually make the recreational program feed greater affordability and access for the medical marijuana program. So have you talked about that before? So I just thought, so my agenda item behind there was just kind of exploring the approaches that are proposed out there and creating some sort of report about that so that we can define best practices that might apply well to Oregon. And this may be just well known to all of you, but for me, just starting that exploration, I thought there might be lessons to learn, not only from states who have had recreational programs for a while, but also those who are seeing it come down the pike and starting to kind of, be innovative on the fly so they can avoid some of the problems that have come before. That was one thing. The other things were just, I've read the report, the SB 844 report, and I wondered, they had two main recommendations. One was to establish an independent research institute, and the second was to clarify expectations for physicians so that, a lot of physicians have these kind of free-floating anxieties about what it means to be involved in recommending cannabis to their patients or being engaged in research. I know those questions come up all the time, even at OHSU, and I just wondered what happened as a result of those recommendations. Should we make movement with them, or is it something we need to go back to?
Yeah, so a couple things. One, it was presented to the legislature, and but again, the funding, it never got funded to do that. Part of the issue, I think folks are aware, to have an independent cannabis commission. Many universities don't want to take on some of the research because they're concerned about other federal funding and whether or not doing research on a controlled substance, well, Schedule I, highly illegal substance from a federal perspective that would jeopardize other funding. So that was the reason for kind of a standalone. There was never funding allocated for, as I mentioned, the research projects like they have in California or Colorado. The second piece around physicians, so I think part of that, again, was the work for the task force or the work group that pulled together the prescribing guidelines for clinicians. They're not prescribing guidelines, they are guidelines for physicians who might be recommending medical cannabis. But again, the idea with those was to really sort of help legitimize, the kind of process. The first thing you do, you talk to your patient, evaluate what are the different things, and sort of having that be part of the more traditional approach to medical care or treatment. And so I think part of the reason to do that was also to give a little bit of guidance to clinicians. So part of that, but I can't say that that was the entirety of that piece, and I don't know, again, what the majority, I'll say Dr. Knox aside, but the physicians who obviously are very comfortable and have some of the compassionate care centers and those kinds of things. Absent that, I don't know how much the sort of mainstream physician who's seeing a variety of patients, how comfortable they are with recommending cannabis.
Okay, then I think in that context, my recommendations would be maybe we can revisit the idea of funding for research. Perhaps the idea of a cannabis institute was too ambitious. And that maybe there's something we can go for that would be very small, a very small research fund, 3 or 4 funded research projects, pragmatic studies, not RCTs, pragmatic studies of maybe real life cannabis use and health outcomes associated with those. Those seem to be the kind of things that maybe we could ask for that's more reachable. And then part of that will be kind of defining what we think is pragmatic and highly relevant needed research, like, just observational data, quasi-experimental studies based on access, things like that. Might be nice to get on the agenda. And then the other part of it I thought might be if somehow we could make recommendations for the development of a research toolkit for healthcare settings. So right now, healthcare, primary care settings, emergency departments, any healthcare settings in Oregon do not systematically ask about cannabis. And we ask systematically about a whole hell of a lot of things. It's all in there, like the things that you need to do to screen, and their standards of care. And cannabis actually fell out when it became legal because we ask, most primary care settings ask systematically about illicit drugs. When it became no longer illicit, we ask about all drugs except for cannabis, which is kind of remarkable. So we have almost, for a state like ours, we are the experts in cannabis. We have very little data, and these are huge administrative data sets. You put in 3 questions about cannabis use, then all of a sudden we have millions of data points and we can do remarkable healthcare research. So I think those are the kind of things I think very practical that maybe we, if it's legislated on a state level, could disseminate very quickly. I mean, I'm sure I'm making that sound a lot easier than it is in practice, but still, that seems to be much more feasible than starting from the other end and trying to get high quality. And like this, I love how this thing kind of times me out when I'm talking too long. And then the last part of it is just speaking to the clinical practice side. I know there are online things, but I just wonder if there's any way we could address the education part, since we are, a state with a big healthcare university, whether it might be within our purview to make some recommendations that have to do with the curricula that our physicians receive. Our physicians at OHSU are the ones that disseminate through the state and provide primary care. So again, it seems like a good opportunity to catch people at this early point, and then they go and give healthcare if they have a little bit of baseline knowledge. If we were to integrate a curriculum into our medical school, things like that that are kind of hard to do from this end.
Yeah, just to piggyback off that, there's a difference between a physician who recommends cannabis for debilitating conditions and a clinician who specializes in cannabis and cannabinoid medicine. So, having a clause that stipulates doctors shall complete, certain number of continuing education credits in cannabis is, I think, good for, a doctor who maybe is not focusing on clinical cannabinoid medicine, but is comfortable having a conversation and deeming a patient worthy of using cannabis. But I do think we need to have, clear expectations that when physicians feel that they aren't comfortable managing patients, to refer them to clinicians who will. And so I think we also need to identify who those clinicians might be, because I can tell you from the study of the endocannabinoid system, it is a field of medicine. We cannot expect every single type of doctor to want to understand the endocannabinoid system in cannabis and cannabinoid medicine to the degree that it may be really beneficial to a lot of people. And so there are efforts being made nationally to establish, like the American Academy of Cannabinoid Medicine, for example, who are involved in developing guidelines for clinical management, ongoing clinical management of patients. And so to echo your point, Madam Chairperson, I think we should start talking about curricula to advance the training of medical professionals. So I see 2 crops of physician types or healthcare practitioner types that could benefit from that.
Thank you.
So just a couple of points. One, I think you're absolutely right, Madam Chair, about the research on cannabis. So if I'm not mistaken, a number of the prohibitions really had to do with being in possession of a Schedule I substance. So that doesn't preclude, as you mentioned, a lot of other types of research, such as observational studies or asking patients what they do, et cetera. So I think that the prohibition or the concerns that universities had was actually to do research. And that the task force also was talking a fair amount about other types of research, like agricultural research and other things that might help the plant product, and what did we know about the genetics, et cetera, that were a little bit separate from kind of the medicinal uses. So again, doing that kind of research implies that you actually have, and I think, again, other folks in this group probably know this better than I, but the federal research that is done or is allowed to be done still has this cannabis from Mississippi, is that right, or whatever, and, you know, most people in the know say that's, you know, that strains that are 30 years old, and it's not nearly what's happening now in terms of, so yeah, exactly, essentially it doesn't mean much for research. So I think some of those concerns that people had were really focused on that, having, you know, the cannabis plant itself. The second thing I was going to say about pain treatment, I completely agree. One of the other hats that I wear, of course, is being very involved with trying to limit the number of people in Oregon who are overdose on opioids or addicted to opioids or other things around. And again, the primary reason that people use cannabis, I think 90% of the patients of their conditions, it's due to pain. And so understanding, we've done a fair amount around pain education, but it's more specific about understanding pain education and then essentially understanding what opiates can do and what they can't do and what some of the side effects. And so I would echo that at least in a state like Oregon, it would be very helpful to include, I don't know whether we need cannabis specific or whether as part of some of the pain training that we're doing or this curricula, we can include both what happens with endorphins or the endogenous opiate system, as well as the endocannabinoid and other systems that people need to understand when they're using different things to manage pain. So again, I'm not sure we need a standalone, a specific, but it could be included in other types of education that we're in the process of updating and developing.
I'm sure if I could add. Thank you. Thanks. So I was thinking, you know, with Jesse's comments about legalization and legalization of recreational marijuana and access, I think that it'd be important to conduct a survey of OMP patients and also recreational users to gauge the how, when, and why they use cannabis. My suspicions now that it's legalized recreationally is that people may still use it for medical purposes, but they use it in the same way that they can go grab Advil off the counter at Fred Meyer or CVS and use it more as an OTC or a supplement rather than having to talk to a physician about its use. So I think a survey of current use of patients and maybe even some recreational users would be helpful in kind of guiding us into the future as far as maybe creating more questions that can be answered or pursuing some answers from questions that we already have.
Yeah, and I would just reiterate the need for that survey to have open and closed questioning, because I think the vast majority of recreational users don't know that they're using it medicinally. So we're going to have to come up with questions to sort of elucidate that, because I think that's actually really accurate, that most people are using it for a therapeutic reason, and I would love to be able to tease that apart with data points. Finally.
I have that data if you want it. Not at OMP numbers, but ER patients.
I would be happy to see it.
Any other? So we already items?
Madam Chair, I just want to make sure that through all of this, we figure out a pathway to satisfy the concerns of the insurers and the CCOs and the HMOs. I don't even know if that's current anymore. You know, these larger providers that, you know, whose administrators, for reasons of liability and other things, don't allow this conversation to happen. And when I was speaking with the director of nursing at our house, she said that there are instances in that she has discovered where a provider will not pay for treatment option if the person's using cannabis. The example she cited was a Hep C treatment, because it's like a 2 to 3 month, 3-4 month treatment, and they didn't want people using cannabis. Some of the providers didn't want people using cannabis. The interesting thing, though, that the comment that she made was those that use cannabis, whose providers allow them to use cannabis, have a higher rate of completion than the patients whose providers don't allow them to use cannabis. So it's all of this sort of maze through the medical community that was one of the most important things of getting this commission together. Was I don't speak medical, and we need people that can keep and know who to call to help, further the integration of cannabis.
I like that topic. I feel like there's a lot we can unpack in there. There are a lot of pieces to that, but I think having that up as a general topic is important. All right, I think if we've reached saturation here, did you find you had a floating one?
No, I thought the OLCC, correct me if I'm wrong, has sort of been playing around with the idea of some of the tax dollars going back to creating an affordability program. I know we talked about the canopy, the bump up for recreational growers to provide free cannabis to patients, but can you just fill us in?
I'll fill you in to the extent that I can. The tax dollars themselves are controlled by the distribution formula and statute. The OLCC, through statute and through our administrative rules, has done a couple things to try to allow access to medicinal products via the recreational system. For example, patients come into a dispensary and they don't pay tax on any of the items that they buy. They are also able to get items with higher potency than rec patients, than rec consumers do. The bump up canopy is another item that you were involved with, where we have essentially allowed additional canopy space for growers who meet certain requirements in terms of donating the yield from that additional space to patients. Another program that I've heard discussed in the industry, which is not regulatory in nature, is a program which would facilitate charitable donations direct from growers to patients. Actually, the regulations would require them to be routed through a retailer, but an organization that would look at need-based applications and direct charitable contributions of product to those individuals. I know that idea has been percolating in the industry. I don't know exactly how far along it's got, but it doesn't really require OLCC or OMMP to do anything. It could be executed under the current structure.
Thank you.
Yeah, that's a very interesting pathway that's kind of opened up, and with all the excess inventory, there's a lot of talk about it, frankly, and it's at the very top of my list is establish and maintain a low-income patient access. There's a number of things I think that need to be considered. The initial conversations revolved around determining their eligibility off of their the fee they pay for their card. So if they're bad or reduced fee for any other reason, they're automatically in. I think that needs a little bit of expansion because there are people that do not have discounted cards that really are on fixed income that need to take advantage of the program too. And this is one of the ways that we can actually expand the program to help, increase our revenues and increase access. And, hand in hand with that, I really think that this commission needs to make it make the public aware that cannabis can help with their arthritis, and they can either choose to become a member of the OMMP, or they can go buy their OTC, at retail prices without the tax. So I think it's important that we make sure that this is kind of the top of our list. Thank you.
If I could piggyback on that point just a little bit, one of the issues that the OLCC has struggled with in our rulemaking, it's not only low-income access, but also the fact that we don't have any standards on dosage for different conditions. So, when we were looking at our rules on the bump-up canopy, for example, we were trying to set some volume limits to prevent diversion on the secondary market. And, the Liquor Commission, as a commission, really wasn't comfortable saying, patient X needs this amount and patient Y needs that amount. But I think one of the challenges that we all have is the regs treat everybody the same. They treat somebody who has a little bit of back pain the same as somebody who has a terminal condition. So that's one thing that I think I'm looking forward to discussing as part of this commission, and hopefully providing some more guidance to the agencies and the legislature about how we can address not only the problem of income access, but also who needs how much.
Is that right, Representative?
And to piggyback off of that, one of the examples is in the transfer amounts back from the OLCC licensees. And I've encouraged people, especially transfers, to think more in the 5, 10, 15 milligram kind of model, so that a patient needs a gram of oil a day, means he needs an ounce of oil every month to get by, but do you transfer him 12 ounces? Or do you transfer him 1 or 3? And then, to help address the diversion problem. Because certainly, under existing rules, it's a bit restrictive and will probably not be exercised very much, so that's one of the things that not just this commission, but the community overall has to start thinking in terms of when we start talking about cannabis as medicine. Yeah, a lot of people are still smoking flower, whatever their delivery modality is, but if we don't get ourselves as a community, our heads wrapped around dosaging and treating cannabis like medicine, we're not going to get the medical community to join us.
Which, to your point, stop using the word marijuana.
Last thing on my list.
Yeah, I feel very strongly about that too. I would like to rewrite along all the legislation to exclude the term and replace it with cannabis. And so again, I also want to reiterate the education of the healthcare professional, not just physicians. Right now in Oregon, only licensed physicians can write for the authorization of cannabis, and that's fine, but I think we need to support all healthcare practitioners in all senses, pharmacists, naturopaths, chiropractors, etc., in being able to have conversations with patients about their cannabis medicine, routes of administration, dosing. We're only going to really learn that without these RCTs by clinical practice and working with patients and collecting that data. Right off the bat, we're talking about Hep C patients. Well, THC actually enhances the scarring, the fibrosis that occurs in a cirrhotic liver. It does nothing to a healthy liver. So there is, a good reason why physicians might not want their patients to be using cannabis without that education. Well, CBD, guess what? Heals a fibrotic, cirrhotic liver. So there needs to be a lot of re-education and redefining really expectations that patients have of their providers and providers of the patients, et cetera. So I think a high priority of ours, not only, I started off saying we need to hear the public at large, I think that includes the concerns of healthcare professionals. And if we open up public hearing sessions to everybody, or maybe if we have ones for lay persons and another for healthcare professionals, I think we do need to educate some of the larger entities, healthcare centers, clinical care centers in the state that does have issues with allowing the conversation to happen, let alone providing clinical oversight. I think for the longest time, healthcare professionals have been left out of the conversation. I think in a large part that's due to us. We've been very, very hesitant to get involved, but I think that ship has sailed and we have to get involved. But I think this commission should absolutely be tasked with supporting healthcare professionals and in becoming comfortable with having the conversations and extending that further into clinical care. The guidelines as they stand that have been adopted by the Oregon Medical Board are literally to help guide physicians through the recommending process and not the clinical management and care and dosing, et cetera. And there are a lot of sort of pragmatic recommendations to dosing for many specific conditions. I'm very familiar with those. And so I think that is a task that we can undertake, and between myself and my colleagues who've been in the space for decades or more, I think we can come up with some really great guidelines for practicing clinicians.
Madam Chair, if I may, to piggyback on by Dr. Knox, then I would say that in one of our priorities for public listening for that, we would include a portion specific to healthcare professionals and maybe work with the professional boards and maybe setting that up and have to hear what they have to say.
I'd love to turn now to the public commentary portion. Oh, sure, that would be great, yes. So we had some submissions by, in writing by emails. We can start with those.
Sure.
Who can see that?
So these are public comments that were submitted previous to the meeting. And I'll just start with the top and go down to number one, and in no particular order of popularity. Please consider SSDI as a reduced fee. So that would be Social Security Disability Insurance. And number two, consider fee for child needing medical cannabis. Currently costs are $200 for a card. That's if you don't qualify for one of the reduced fees. So, I mean, the comment basically was that there's a lot of costs related to getting cannabis for a child, which include doctor visits, and then cannabis purchase at a dispensary, and then the administrative costs associated with getting a card. Number three would be expand the illness and diagnosis required to obtain a medical marijuana card. Examples provided would be autism, attention deficit hyperactivity disorder, SPD, I'm not sure what that is, and then OCD, which is obsessive compulsive disorder. So there would be an expansion of the medical qualifying conditions. Number four, some legislative changes. Grow sites at less than 12 mature plants exempted from all tracking. B, allow any grower to transfer to any patient. And allow medical growers to transfer to any dispensary, OLCC or OHA with no limitations. Allow patient grower registrations to be 2 years instead of 1 year. Number five, provide pesticide education. Number six, re-implement the advisory committee for medical marijuana with making them publicly accessible. Number seven, pathway to create pilot programs to better serve patients. And number eight, reserve green cross symbol for medical only cannabis.
Was there anybody who wanted to comment in person? And so why don't we have a stray mic right there at the end of the table who wanted to come and join us here, and we were going to have people. Carol, did we have sign up? Do we know how many people wish to speak? Why don't we see, because that will determine how much time each person gets.
Testing. Yeah, as much time as you can get.
13.
You're such a time hog, Rob. I know.
We're a little bit ahead of that.
Sorry, I don't think
Can
so.
we do 20? We can do 20 minutes. Okay, so there's 13 people who want to speak. We had initially allotted only 15 minutes. I think we have a little extra time, so I think we can give everybody 2 minutes or less, but we're going to have to go really by the book. So we will literally, I think we can take a cane and move you off just to be respectful later. Okay?
Go.
Start with your name for the record. Start with your name for the record. My name for the record is Michael Rockland. I am a cannabis nurse. I've been in Oregon for a while, immersed in the industry, both medical and legal. I don't like to say recreational because that's what DEA is like. Anyway, a couple thoughts on these priorities. I think they're wonderful. It's a lot to chew off, but I think consolidating all that, plus what I've testified on in the past. Number one, licensing protection for healthcare professionals. So that tags back to what Dr. Knox said. that all healthcare professionals, and in this state we only allow DO and MD to authorize. In Washington State, there are several nurse practitioners, PAs, MDs, and I would like to see parity because look where we are with a healthcare crisis. We don't have enough providers. So nurse practitioners, PAs have been the front line, and I think I'm hearing from a lot of my peers on that. So that's a big one to attack. And also, it would help because I belong to the American Cannabis Nurse Association, and we've developed protocols for NPs. So that might help exactly what your point is. It's simple protocol to tell NPs, nurse practitioners, how to dose, how to treat, things like that. Kim at our house was part of that, who's a fabulous nurse practitioner. Second thing is funding, and that is always the case. What I heard last night with Senator Steiner Hayward was that she is sponsoring a bill to make some fixes to the tax, which Jesse referred to, distribution. I would suggest we consolidate and recommend something to tag with that in terms of some of the funding issues, so that not everything, but in terms of research, education, public outreach, things like that, the tax for the retail adult use could be changed a little bit, fixed, if you will. That's what she's calling it. I agree. I think the initial measure was not clear enough. The intent was there, but as we've seen in 2 years, we've seen a lot of impact on the medical program. Card holders have gone down, growers have gone down. Where have they gone? They're still there. So, those beg the question. In terms of need, I think all use is therapeutic. I want to say medicine, but it is therapeutic in some way. Stress, pain, things like that. And finally, in terms of research tools, again, ACNA, American Cannabis Nurses, have these. They're developing education, things like that. So I've offered that. I'm a member. I'm not representing them. But I think there's enough people that are interested to participate in either a subcommittee or something and get your hands around that and bring it back to you all so you don't have to reinvent the wheel. And finally, insurance. I think reimbursement for services is a priority and an ultimate goal to get to reimbursements. Medicaid, for example, as an RN, I can't bill directly for my services. I have to go through the attending physician. It's cumbersome, it's complex, and it's time-consuming, and frankly, it's not worth it for the fees they have. So those are comments I have, and I think that what you're doing is fabulous. I thank you for the time and willing to participate in whatever fashion. Steve, thank you.
Thank you for coming and speaking, Mike. I'll just go from the top of the list. I have Kevin, starts with this, Cleveland, maybe? Kevin. Next is Jason Beaner.
I'll defer my time for the commenters.
Sunny Sanchez.
Hi, that's me. So, my name is Sunny Sanchez. Okay. My name is... Hi. Excuse me there. My name is Sunny Sanchez, and I'm a resident of Benton County. I'm also an OMMP patient until the 1st, and I'm a grower. And one of the things that I haven't heard in this commission meeting is about efforts to minimize the margin of diversion. I had a conversation with someone in the industry, and after speaking with him on some issues, I believe that there is probably, most likely, some tightening up at the processing level that needs to happen. I don't know if you're aware, how many, I know you're not supposed to answer questions, but I just want to know if all of you know the difference between a concentrate and an extract. Okay, well, okay, so anyways, you know that the returns, the yield of extracts vary greatly, and that is one of the huge concerns about possible, I guess, leakage to the illicit market. And I just also, secondly, I wanted to ask if you had any commentary on the AOC's proposed taxation on some of the southern Oregon counties. And then I would also like to ask the commission to provide materials for the public when we come in, and or make it available online prior to the meeting so that we can be up to date on what is being discussed prior. And another concern is double dipping in the program for OMP as well as recreational providers. How are you going to prevent people double dipping, getting more product than they really need? So anyways, that's all, and I will pass it on to the next person.
Thank you, Sunny.
Yep.
I have Don Esch.
I just have a couple things, but I'm a veteran. I'm a veteran and
State your name.
Don Esch. Veteran and a medical card holder. And one suggestion I have is, it's kind of a nuisance to have to go back every year and get your card renewed. Now, if I can use an example, for your driver's license, it's every 10 years. So why couldn't we have it, say, 5 years for a card, or something like that, where you didn't have to go back every year? I've lost my train of thought there, but I'd like to see more done for the patients. It seems like you read about all these amazing figures, amounts of money that the state has made off of cannabis, and it always goes to anti-drug groups like Nurses Against Cannabis and stuff like that. And I'd like to see more done for the patient in the long run. It seems like the voters of Oregon legalized it, but it doesn't seem like it's legal. We're still like second-class citizens. And I find that kind of amazing. It's like it was decrimmed, like it wasn't legalized. And that could be disheartening at times, and I'd like to see that change and sometimes do something for the patient. I know the rolls are down for medical. Still a lot of people getting their medical cards because they don't, I like the fact I don't have to pay tax on it. But doing more for the patient would be, sometimes would be a great thing to see. And when I go to the doctor and get my card renewed, last time I went, he stated this is just to satisfy the state. Filling out these forms. So it's pretty cut and dry, which, I just thought it was an odd thing to say, but I'm happy that we have it, the medical program. I worked on the medical and recreational, getting that legalized, and I'd like to see more for the patients. Okay, thank you.
Thank you.
I have Dan Kunzer next.
Dad, it's your turn.
No, I'll pass. Thank you.
Sean Lee.
Hello everybody, my name is Sean Lee. I'm an OMP grower and caregiver. I'm also a soil microbiologist. One of the issues I've heard you guys talk about a lot today, the relates to what I want to say is the medical research and how to establish pragmatic, real standards and data involving this organic compound that comes from a plant and has, as we've identified, I think over 100 cannabinoids at this point that exist, and they may keep evolving and may keep producing even more cannabinoids. So what are the, I guess, priorities that you are entertaining in your minds for establishing that real data? And what are the risks associated with establishing that real data when it comes to producing this product? When you're in the agricultural world, there is a massive force of biology that you're starting to take part in, being part of. And smells is one of the ways plants communicate to us. And they attract many different things besides humans. And we're talking about a flower that is very pungent smelling, so it attracts a lot of different things, some good and some bad pests, which cause people to use toxic pesticides. What are you going to do about addressing people who use toxic pesticides that sometimes end up in the product, sometimes in our water systems? Are you going to create any requirements for people who are creating this product so that they don't create a product that is tainted with harmful toxic chemicals that are going to cause detriment to many different organisms in this environment, not just for the patients, but for our water systems, for our soil systems, for all the different living organisms that we share this planet with. Yeah, that's the gist of what I wanted to say. Thank you.
Thank you, Sean. Leland? Sorry, can't read your last name.
That's okay.
Berger.
I'll take that. What is it? Hi. My name is Leland Berger. I'm a lawyer and an activist. I co-wrote the Medical Marijuana Act, Measure 33 and 74, and Measure 91, the legalization initiative. I'm the immediate past chair and co-founder of the Oregon State Bar's Cannabis Law Section. I'm a co-founder and member of the Board of Directors of the National Cannabis Bar Association. I'm co-founder and chair of what's now the Oregon Normal Legislative Committee. I want to respond first to things that some of the presenters said. And I know I got here late, but I got kind of the gist of what y'all have been talking about. And then I had some specific suggestions and recommendations. And actually, I want to really first mention that last week, Dennis Perone passed away. And Dennis was the energy behind Proposition 215 and the medical marijuana law in California. And he's the one who coined the phrase that all use is medical. And while it may be more accurate, as Mike has suggested, to say that all use is therapeutic, it's nonetheless true, and it's bearing out in our legalized retail licensed facilities, which it's partly for the tourists, right? And it's also partly for people who don't usually consume. And a lot of those folks are older folks that are looking for alternative things for their aches and pains. So I just didn't want to let today go by without mentioning about Dennis. In both 2003 and 2010, we worked really hard at crafting an indigent patient supply system as a part of the proposal. And by the way, the response about how much do people need is easily answered. It's how much their physician thinks they need. And for a long time in Oregon, the Medical Marijuana Act was premised on that. that a physician could write patient needs 14 plans, for example, because the physician knew that patient knew how much that patient could grow and how much that patient needed. And that's a question that should be entirely deferred to a physician. It isn't, because some folks at OLCC and some folks at the legislature think that the only physicians, not you of course, Dr. Knox, but that are involved in this work, that it's just a sham. And you know, that's a thing for the Board of Medical Examiners to do. That's not an issue for regulators and for this group in terms of making a recommendation. If you're going to make a recommendation about how much do indigent patients need and how to assess that, then include it in the form of the doctor providing that information. So I took the minutes from people who.
Oh, that's
I'm just getting warmed up. Hi, Shannon. Thanks for causing a problem about the number of plants. We don't have a diversion problem. We have or an oversupply problem. We have an insufficient market problem. And the solution is to expand the market. And so what this commission can do is it can recommend to the legislature that reconsider a bill that was before the last session that would have empowered the governor to have contacts with adjacent states like Washington and California, in the same way that we have contacts with Indian lands and tribes for free trade. I had proposed in a letter to the editor after the election last November that Congress take up allowing interstate commerce between the four coterminous western states, Washington, Oregon, California, and Nevada. Certainly the commission can recommend to the legislature that they do a sense of the legislature bill to recommend that Congress take that action. There isn't anything that prevents you from doing that. And then lastly, the work I've been doing since legalization, since forming the normal legislative committee, is work on ending cannabis bigotry. And last session we had bills that would have ended, as introduced, would have ended employment discrimination. And we've been working on social consumption. Unfortunately, on the social consumption issue, one problem we've run into is the Indoor Clean Air Act, as it's been advocated for both by the OHA and by the local health people, and it is just complete nonsense to utilize tobacco studies and say that that's applicable to cannabis. So taking a different position would be helpful. I'm almost done, I promise. The other areas include family law. In Massachusetts, for example, they have a bill that would, or provision that makes it so it's not admissible as evidence in a family law case, the fact that a parent is a cannabis consumer. I do think, though, that the biggest issue is, particularly with the way the legislature has limited the number of medical growers. And while I started out by saying that all use is medical, the fact is that some use is medically necessary, where there aren't really, and by that I mean that any other substance is not as efficacious or the side effects are intolerable. That's a legal definition for that. And the very last thing is, it's remarkable to me that the health authority hasn't moved forward on cannabis substitution for opioid addiction. In my practice, I've seen the recurring, in my law practice, I've seen the recurring fact pattern of traumatic injury, hospitalization, massive dosage of morphine, taper down, discharge, a supplemental medication provided runs out before the pain ends, alcohol use, opioid use, heroin use, whatever it is, addiction, and then learning that cannabis is a legitimate analgesic and utilizing that to taper off. So one proposal I've heard from a retail person is coordinating with the DEA on their drug turn-in day, which this year is April 28th, and having opioids being turned in at retail and medical dispensaries and free cannabis being given in exchange. That would also help with the overproduction problem. And I appreciate your allowing me this extra time and your patience with me generally. Thank you.
Thank you for your comments. I have one last, if the rest of the commission is okay, 1 more minute for a last comment. I have Christine Everett. Christine E.
Thank you, Madam Chair.
There we go.
Thank you, Madam Chair, members of the Commission. This is Christine Everett speaking on behalf of the Oregon Sun Growers Guild. And today, if you'll allow me, I will keep this brief. In the interest of time, my clients have prepared a comment that I would like to read into the record. So the Oregon Sun Growers Guild is the state's largest cannabis nonprofit organization advocating on behalf of sun growers and OMMP patients. Our mission is to advocate for and promote sustainable sun-grown cannabis, family farms, and conscientious consumers. We have been involved in all aspects of Measure 91 implementation through our lobbying efforts, by serving on every state RAC and committee, and by working with all state agencies involved in cannabis policies. And we were very active as well in promoting the passage of House Bill 2198 and are happy to see you all here. We appreciate your hearing our comments and concerns today, and congratulations on your appointments. The Oregon Sun Growers Guild and our members are extremely encouraged by the formation of the Oregon Cannabis Commission. We wholeheartedly support you and your mission and look forward to being a resource for your myriad considerations now and in the future. When Measure 91 was presented to the Oregon voters, it was explicitly stated that this adult use proposal would not affect the Oregon medical marijuana program. Now, just a few years into the implementation of this initiative, we're seeing the demise of the OMMP. The OMMP has lost patients at a 25% reduction in 2 years. There are less than 16 medical dispensaries, down from over 400 prior to the passage of Measure 91, and less than 13 medical processors remaining. These statistics are staggering in and of themselves, yet the real stories are what is happening in people's day-to-day lives. Patients can no longer access medical dispensaries with products and staff support specific to their needs, which are distinct from adult use consumer needs. Medical growers have a very limited access to the retail market for our products. The specific medical strains we have cultivated for decades are so valuable medically that they're at risk of being lost and being replaced by high THC strains the adult use market requests. Oregon's medical cannabis growers are the experts in this field because in many cases we've been cultivating for over a decade, not just a year or two. We value the relationship we have with our patients, cultivating what proves to be of most use to them. Those needs can change, and we grow strains according to our patients' feedback. This is a compassionate program at its heart, and the grower-patient relationship is now at risk of being pushed out of existence. The real numbers are yet to be determined as to how many patients will be without a grower this year. Driving to a recreational dispensary, paying retail prices, and hoping that preferred medicine and mode of delivery are even being offered is not possible for the majority of OMMP patients. Our concerns are with these thousands of Oregonians, mostly vulnerable citizens, in many cases elders, veterans, and people with disability. The Oregon Sun Growers Guild wholeheartedly supports the mission of the Oregon Cannabis Commission to serve as stewards of the OMMP, to advise the agencies, and to ensure the viability of the OMMP through wise and compassionate policies, and research into the best medical practices for medical and horticultural purposes. We look forward to being a resource for the Commission as you work to ensure a viable, stable, and strong medical marijuana program in Oregon. Thank you very much.
Thank you. I have one last, is it PK?
Be their closer.
Yes, and I see. You're the closer. This is a big responsibility on this commission. Bring it home. And I see your written testimony as well.
Hello, my name is Pete Kramer. I'm from Mercy TV, Alice Allen.
Lean forward. Yeah, there you
Okay. Do I need to repeat my name? Okay, I'm a concerned citizen. I'm a OMMP member and grower. It's only a plant. I use cannabis for my carpal tunnel. I made up a healing oil that is so marvelous that it relieves the pain. My main concern is the patients losing their growers. To pay the ridiculous fees that you're asking the patients to go through. How the OMMP should go back to the original law of OMA, where we're helping patients out. Really, many things I could say, but I'm glad that we're doing this and having the conversation. And this would be on the CCTV down in Salem, and I believe down in Eugene as well. So the patients are being heard. Thank you for your time.
Thank you.
Thank you.
So this is now thank you all for coming. I know some of you traveled some distance to have your say, and I appreciate it. We are listening. This is the moment in the program where we take a 5-minute bio break, and then limit yourself to 5 minutes if you can, and we'll see you back here. We're a little off schedule. So a couple of things. I actually have to leave promptly at 2:15, so at that point, Rachel will take over the reins and move us through the rest of the agenda, and I can weigh in afterwards as needed. The next piece is a little bit experimental, and I hope that this is all okay, but if you, I guess for the commission members, if you find this exercise to be not as fun as I thought maybe it would be, give me that feedback and we'll do it this way again, okay? But I don't want to sit still for very long. So we are actually going to, now revisit all the comments. Sorry, Katrina, I just got started. The next piece will be a sort of an activity. We're going to revisit all the suggestions that were made, and we're going to come back to them with a couple of things in mind. The first is the purpose of this commission. So going back to our bylaws, we have, I would love if everybody wanted to open it up. We have these roles and responsibilities. So I just kind of want us to, we'll take a minute, and before we launch this next activity, just kind of review those and keep them in mind. So as we create our priorities for the next year, just to make sure that they fall comfortably within our realm as the OCC. So that'll be the first thing. The second thing is, we have many things on the table that we mentioned in the past hour that are more long-term goals, or things that will be hard to move the needle on in the next year. And I want us to have concrete things we can actually sink our teeth into, and make legislative recommendations that are likely to actually happen, so that we can feel really good about ourselves, but more actually move things forward for patients. So I would say a bunch of baby steps that we can accomplish, I would prioritize over things that we know are long shots, at least for the short term, knowing that we're a 4-year commission, perhaps some of those things we can tackle in year 3 and year 4. And I guess the final thing is we are all human, and they need to be things that are within our bandwidth to accomplish. Even though we will have some extra resources, we can bring in experts in. For example, say one of the priorities were to be development of a curriculum. That's a huge resource thing, but it may be that we do some fact finding and see if there's enough existing materials that we could use. That's just one example. But if there's it might be that we say that's a high priority one, but first let's go out and do some fact finding and see what are the resources that are here in the state of Oregon, existing curricula, things like that we could take advantage of that might turn that from a 4-year goal to a 1-year goal if we're building off something that exists. So with that framework in mind, we are going to get stickers. All right, so you have these stickers, and we're gonna, we can all just walk up And what I would say is, you can't use all of them. You can just use the green ones as your highest priority ones, and then your yellow ones as the next priority. So you actually have 12 things that you can prioritize, but the green ones we'll pay attention to first. And you can be creative. If you feel like there's something up there that you like but you want to add to it, just take a pen up and change it. Or you can consolidate ideas there, you can specify, or you can add on if it's not worded exactly the way that you want. Okay, so I thought we would do this for, I'll just keep an eye out for when it seems like people have committed, but I was thinking 10 or 15 minutes for this.
Can we stuff the ballot box?
Yeah. Another question.
In other words-
Can we load up one category with
Yeah.
all 6 of our green dots?
No, and I might not want to do that, but,
Well, I mean-
we've articulated things like the need for research, so I might put more dots related to.
I had not thought about that. Let's say yes. I think let's keep this open. Like you can even negotiate with each other. You can be like, you will green this, I will green that over there. Let's leave this really open. Carol doesn't like that. I feel like we are going to be, we're pragmatists, but that's the way that priorities happen. I think that's totally fine. Anthony, do you have any suggestions?
Yeah, well, I kind of wanted to go along with that because we did this exercise in 2012 before 2013, and we prioritized in our top 3 ones. We got through the legislature, so I think this is a very good exercise, and by prioritizing, it really gives us a sense of what it is we can accomplish.
Okay, I love it. Yeah, and you know what, now that I think, but I think the pile-on is okay. If you want to put all your chips in one basket, I think it will do something for us visually. You know, if we see that is so important to someone that they're willing to spend down all their greens, I think that's something that we want to convey as a group, so to each other. All right, so go.
All my greens on red.
Oh, yeah, actually, and so the reds, I'd say the reds aren't a vote, but if you feel like you really don't like an idea, you can red it, meaning that you think we should take it off. You know, you should take it off the list. I think there are some red things. All right, why don't we come back together and I'll need my scribe again. So my thought was to pull out the things that had at least one green. Does that make sense? I feel like somebody needs to feel passionately about it, otherwise they really shouldn't be here. So I know you guys were gaming with the yellow pile-on towards the end. Let's just ignore those for now and see if we feel like the agenda is rich enough and comprehensive enough, and if not, then we can go to the yellows. So just starting at the top, minimize diversion. Let's pull out that one.
You know, diversion is not a state issue.
I respectfully dissent from Mr. Taylor's comments there. Diversion is absolutely a state issue. It goes to the viability of our state recreational and medical marijuana programs as a whole.
Wholeheartedly second that. It puts all of what we've worked for, especially Anthony, the past 30 years, I think, in jeopardy.
I really do agree.
And there's a simple solution.
But if the feds would just legalize, it would no longer be an issue. It'd be legalized commerce.
That's right. It's a congressional issue, and Congress can do something about it if they really wanted to.
Okay, number 2, establish and maintain low-income patient programs. And that is represented a few times here, so I won't repeat actions from low-income patients or that aspect of access. The next one is improve, streamline, and expand the program through legislation, public awareness, outreach, and education aimed at those Oregonians that can benefit from its use that are outside the program. Yeah, I think maybe just looking at that, that's a pretty broad one. So we can talk about that more later. The next one is develop recommendations for better managing cannabis patient care from start to finish, including how providers and insurers participate in the care. So that's number 4 on that same sheet. And then develop a proposal for funding and directing research related to medical cannabis. Yeah, you can do that. We can just circle those and then stick them up there.
And just note that they're there.
Because I feel like
Trying to write
I'm
them.
torturing you with these ones.
Yeah, you can get 4.
Okay, number 4.
It can either be fast or legible.
Number 4 is the one that, on that sheet that says develop a proposal for funding and directing research related to medical cannabis.
One after that.
There was another one. The one after that is the public hearing tours. Let's see, we've already covered that one. The other, next one is developing protocols for dosing and treatment options. The next one is ensuring integrity of product, including random testing. The next one is exploring, defining best tax practices from other legalized states. Number 9 is to define guidance. Actually, 6 and 9.
Yeah.
Maybe just cross that out. Thanks. I think that's close enough to protocols for physicians. The next is develop a research toolkit for healthcare settings. The next one is to, I think the way that I would articulate this, address, so the next one will be address cannabis use within pain management training. Address cannabis use within pain management training for healthcare providers.
Did we skip number 14, Madam Chair?
No, that's no, right next.
Okay.
We're just integrating it with one episode.
Oh, okay, thank you.
The next one is to survey OMMP and legal use and recreational users.
Or just say patient/consumer.
I think that's good. Yeah, survey. That works. The next one is replace the term marijuana with the term cannabis in rules and statutes.
Just find one.
The next one is to include professional and medical associations in developing new recommendations. Yeah, professional/medical. In developing new recommendations related to cannabis.
Okay. Those, you guys can see. Yeah, why don't we put those front and center? Just move these over. That'd be great. And then we can.
Then we take a vote on it.
Let's see. So. Medical
Why don't we do that? Why don't we take a few minutes? We're just going to do some discussion up here and figure out how we can package some of them together, and then we can revote.
The audit itself, around testing, diversion, so I'm just big on, you know, what is it we train clinicians for, what is it we think about the product, and then the third point is the piece about patients and ensuring access for low income. I haven't looked at all of them, but I don't know how many would fit those kind of three big ones.
I'm
Then
going to
there's some-
add research as a fourth one.
Oh, yes, research. How could I have forgotten?
It's been a busy day.
My gosh, those seem like the three big ones. All right, so let's see what falls under training. I think there's a number of things.
I would say clinical or training, so number 6.
Nine in there.
But this is a research toolkit.
Which research? Or just the things working, that could be training.
It does training.
Did you circle, was there an opioid one?
There was a pain management.
Yeah, there's that opioid.
Oh, it's there.
Sorry.
Cool, I can
Yes, yes, right, good.
And this is actually, I feel like we should probably do this. I don't know that this is, I just think that we need to accomplish. So this is more of like how we're going to accomplish some of these other things. So I think we can actually take this off. I think we all feel like we need to do that as part of accomplishing other goals. Okay, so that's, okay, so where did that go? That's
One.
training, yeah, training. So developing recommendations for clinicians. And integrating into pain management. Does that sound pretty well? Okay. And doing this in conjunction with professional medical associations.
But again, that's more a how, not a what.
Yeah, that's a how, totally, okay. So then let's talk about the product.
Number 1. 7.
Does that seem right? Okay. Okay. So now let's talk about access for patients. This probably got the biggest.
3. But 11 again is how, it's not what.
This is the survey, right, exactly. So this is something that we will do to inform what we do. What was the other how?
The public listening, and another how was including the medical professionals.
That's right, this was a. Just for now. Okay, so this will be. Okay. All right, lastly, research.
It was more about research than just the toolkit. I know that this was a similar thing, but if we look over,
Well, we had develop a proposal for funding and directing research related to medical cannabis.
It was this.
Okay, that's it.
Yeah. Yeah, thank you.
yeah, so
Yes.
it just didn't get abbreviated, but I
It
did.
did, right. Develop a proposal for funding and directing research access. That one was the patient care one. And research toolkit. Okay, so research here. Okay, and then the only thing we didn't really cover is this one.
The case can be made for that being a how, another how.
I think it's a how. I think no matter what we recommend, there has to be a funding stream for it. So should we call this a how? Leave it off. All right.
So I was just looking behind you, there was one around directing funding further research the small products. It didn't quite get captured in the first.
Yeah.
I don't, is it funding stream?
That was what.
Small directed projects.
What I was small directed projects.
Yes.
Yeah, I like that one.
All right, so let me read this from start to finish, and let's see if you feel good with how it gelled.
All right, so we have 4 kind of domains. The first is training. So we'll work on developing recommendations for clinicians and figure out how to integrate training around cannabis into pain management materials or educational products. The second is around the product itself, so to minimize diversion and ensure product integrity. That's a pretty lean and mean one. The third is access for patients. We'll establish and maintain access for low-income patients and improve, streamline, and expand the medical marijuana program, cannabis program. The fourth is around research. So we'll develop and integrate a research toolkit that can be used in healthcare settings as to identify a potential funding stream for research and suggest a number of small directed pragmatic research projects. Those sound like both high priority and not too overwhelming for a first year. Okay?
Oh, we'll have that done by July.
No problem. Okay, so I think what we wanted to do then is to take those priority areas and then start to articulate what we will need, the resources that we need to develop those into proposals to the legislation. I mean, a lot of it will be sort of developing language and specificity and figuring out exactly what we are suggesting. Some of it may be fact-finding, figuring out how other states have handled this so that we can propose it in a way that is as feasible as possible and has some precedent. That sounds like a really daunting task, so I'm just going to hand the reins over to Rachel now. And I will love to see what you come up with. Now, I'm really sorry, I have to step out right now for my other obligation. But so we're gonna, the next part will sort of be like, what do we need? What are the action steps so that we can get there? And then we'll conclude with decision making about the next time and format of our next meeting. And I'm pretty open, so we'll leave it up to whatever the group decides. Okay? Thank you.
That's okay. So how do you guys propose we do this? Do we want to go through each of those 4 action items, if you will, and address what resources we may need to identify there? Right off the bat, we have these several how-tos, which I think can facilitate getting started on how we want to proceed with these buckets.
Another question, the number 1, training, developing recommendations for clinicians, is that regarding dosing, administration?
Yes.
Sorry, I mean, just
right, so that's
losing some of the...
covering, so orange, we had circled protocols, dosing and treatment, integrating cannabis therapeutics into addressing the
opiate crisis, so in pain management. I didn't wear my glasses, like for number 4, it was like develop recommendations for better managing the patient from start to finish. And the how-to that was identified, so it wasn't included on there, was including professional medical associations in the development of said recommendations. So in Oregon, I would assume that means the Oregon Medical Board. Right.
So I think the first step there, as it relates to dosing and treatment, would be to gather the available literature and put it in one place where we can have some sort of literature review, or organizing the available literature and science that's there, because I don't want to make anything up.
Madam Co-Chair. So I know that there are some starting places for that. So rather than us amassing, for example, the National Academies of Sciences that recently, engineering and medicine, but that recently released, there was a lot of data there about what cannabis was potentially effective for or not. So I think there's some starting documents that we might want to come to my knowledge. And Dr. Knox would know this better. I'm not sure that that document addressed the dosing issue, but still around kind of what the evaluation should be, how you document. Again, our Oregon-specific guidelines are mostly around evaluation and documentation, but then referring to some things that have been published in the literature, I think would be helpful.
Yeah, I agree. I think initially for developing training, you start with the basics anyway, so I think that is the first item and priority item in tackling the first bucket. And I really don't think we can move on from there without doing that. So I'm okay moving on to the next one.
So I just have a process question about it. Back to the Senate Bill 844, but actually that was a fairly extensive process in terms of literature review, et cetera. We had gotten some funding from the legislature to do that. We had a contract with Oregon State University to help do sort of a lot of the work, and then the committee reviewed that and endorsed it, for lack of a better word, and it was presented to the legislature. So I guess to me, that's sort of both what. So we talked about reviewing available, but then there's the how. So I thought part of the purpose of this commission wasn't necessarily that we all have the bandwidth to do all this work, but do we put something, for example, in draft legislation that talks about what the steps are that need to be and what the resources are for us to do justice or to do service, as opposed to saying, well, we'll just look at the NAS report and just adopt that many questions. I mean, that in and of itself isn't helpful, because people need a little bit more concrete or specific. So I'm just wondering about the process, again, the work that this committee is supposed to be doing, commission is supposed to be doing.
Yeah, and in addition to that, right, we can develop subcommittees. And I think for this purpose, it would be great to have a subcommittee of researchers, clinicians who are already, integrated into this and are well researched to date. I think we could probably easily identify a group of people willing to step in and do that work. Because speaking from experience, it is a lot of work vetting the literature and then synthesizing that so that it can be used to train. It can be very, very complicated. So I think we should identify it at one of our first subcommittees to fulfill the role in fleshing out our contributions to training programs.
We could probably use a chair for each one of those categories.
Yep. All right, moving on to products. So minimizing diversion, ensuring product integrity. What are some short-term goals? That we can identify to achieve that.
So Anthony and I have probably been arguing about this issue for 3 years, and we haven't come to any good conclusion on the best way to minimize diversion while maintaining patient access. I put all of my, or the majority of my green dots under minimized diversion, because that's the issue that I see most in my day-to-day life. And that's what I hear from law enforcement and others, is that we have a major oversupply problem in the medical system on the grow level, and that Oregon is a major exporter of medical cannabis to other states. One of the problems, if you will, here is, I think, a lack of comprehensive data. I think everybody admits that this activity is happening, but they have very different viewpoints about the level at which it's happening. And they have very different viewpoints about what we do to curtail it. So that's a really long-winded way of saying I don't have a good answer. I think the best thing we can do here is try to get some information from OMP about the number of grow sites, try to get some information about what type of yield those grow sites would produce, and try to match those production estimates to the estimates of patient needs, and then perhaps we make the assumption that the excess is being moved in ways that are inappropriate. I know that that's a very big task. It's fraught with all kinds of legislative politics, but that, you know, that's the issue that's kind of foremost on my mind.
So I think that OMP can certainly help with quantifying the data or getting some data, some estimates on yield from the medical program. And I think matching that up on what the needs of the patients, I think that would require information gathered from a survey. And then you could do some analysis and mesh the two numbers and the two sets of data together to come to some conclusions. And while I have the microphone and it's hot, I'll stay on product integrity. So I think first steps to ensure product integrity is that there will be in the near future, a meeting between the three agencies that are responsible for ensuring product integrity, those being OHA, OLCC, and ODA. And those three agency heads will have to have a conversation on how to establish a random testing scheme and how to provide additional laboratory oversight. I feel like there needs to be some more regulatory oversight of the laboratories right now, and then there will need to be a random testing scheme established to ensure that the products that are being tested by these labs are indeed what they say they are. So I think first steps there would be to get the buy-in from the three agencies, and certainly report back to the Commission on the results of that meeting. I think that would be an important first step. Shannon can correct me if I'm wrong, but I think that the statutory authority and the rule authority is there, or can be there, as far as the rules are concerned. And the big question, of course, is funding.
Chair, if I may, Andre, you and I are pretty well steeped in the current testing regime. Could you give a thumbnail of kind of what the current regime is and how it works?
Sure. So currently, I'll go back to pre-legalization days, is that there was labs were available and provided a service to growers and processors because there was a desire from consumers to know what the potency of their product was. So everybody wanted to know, well, how much THC is in this? So that you have this little testing industry that pops up and says, well, I can provide the service to you. I can tell you how much THC. Well, legalization comes along and the testing services get a little bit more complex and develop and become an integral part of the cannabis industry. So the system that we have set up in Oregon is that we have a pre-market assurance testing for products that come onto the market. So, and we allow private laboratories to do that testing. And we set standards for private laboratories. So we say, well, if you want to test marijuana and have that marijuana come onto the market, you need to go to a lab that's accredited by a national organization, and according to statute, is the accrediting body for environmental laboratories in the state of Oregon, which is ORLAB, and they use what we call the T&I standard. In addition to being accredited laboratory, environmental laboratory, you also need to be licensed by OLCC and get a license and to be able to hold this and possess this product legally. So right now, currently, the only type of assurances that we have that the product is what it says it is and that it's not contaminated or adulterated is that these private labs are doing this testing. The problem with that is that these private labs have a profit motive and they're part of the industry, and they're not going to be an objective tool to assuring that the product is reasonably safe and not adulterated. So what we need is pretty much a government agency that is going to do some random testing, similar to what the FDA does for agricultural products. I think Colorado and Washington do have some random testing process through their state laboratories. I'm not sure.
I think Washington is moving in that direction. I don't know if they're there yet.
Okay, and Colorado does. So, what would happen is the state would come in, whether it's OLCC or OHA, get some products, probably from a wholesaler, not really from a retailer, and then have them tested at a state laboratory to make sure that there is no adulterants or illegal use of pesticides, or that there's truth in advertising, that the potency of the product is within a reasonable range. So that part is there in rule. The random testing is allowed for. We have the authority to do it. It's just that we haven't done it yet. The other aspect, there's three prongs to product integrity. One is that you have this pre-market quality assurance, which is your private labs. The second is random testing through a government laboratory. And the third is education, because we really need to turn the culture around in cannabis growing, is that, there aren't pesticides listed specifically for use on cannabis because of the EPA is not going to accept those applications from pesticide manufacturers. And I could go into how pesticides are approved by the EPA for use on specific agricultural products, but I don't have that time. So ODA has a program where if a producer is caught the first time using a pesticide illegally, they can go into what's called the MCAP program, and that is the Marijuana Compliance Assistance Program. So the grower essentially says, look, I didn't really know that this stuff was illegal. I didn't know how to use it, because obviously there's not any specific labeling for this product for use on cannabis. And ODA says, well, we'll accept that. You still violated the law. You used pesticides illegally, but we'll go through this education program so it doesn't happen again. So the third prong is education for growers on what products they can use, what products they're not allowed to use, and so forth. So I think, I went long enough to kind of describing that, and now I lost my place. But what we really need to focus on here from the agency's perspective is this randomized testing scheme, because there are real risks associated with not having sufficient government oversight over these products, and just relying on the private industry to tell us the product's okay.
Madam Vice Chair, so do we have in place yet a recall protocol? Because didn't we bump up against that with pesticides originally and had to, in McMinnville as a matter of fact?
So I can answer this question as to the OLCC system. We do have a recall protocol in place. This is for products that have found their way to recall, to retail that need to be recalled. It hasn't happened that often. I would echo Andre's comments about oversight of labs. We have essentially privatized a public regulatory function with the way that we've set up these labs. And I think the agencies, plural, are still struggling with the best way to provide proper oversight to these laboratories.
So is that what we want to accomplish? To provide that advice?
Yes, I think so. And I don't know if this falls under the prong of providing advice to the legislature or providing advice to the agencies. It could conceivably be both.
You know, when I'm looking at the function of the commission and then what the agencies have to do to effectively regulate cannabis in the state, I think that this type of regulation is going to move forward without the commission anyway. But where the commission is important is making the recommendations for paying for it to the legislature. And that's kind of the issue that I see that the agencies are going to struggle with and try to get some buy-in from the policymakers.
If I may, Madam Vice Chair, part of the issue with the diversion is, I don't know if anybody noticed it, but when Jesse was talking about it, the first thing he said was medical marijuana. And this is a kind of a issue of contention amongst the medical growers that having all this diversion laid at their feet when that is not actually the case. Maybe you could stipulate that by definition medical marijuana growers were exporting, but it's not the only avenue of diversion or the only group of people that divert. We have, you know, people that are growing illegally under the cover of either program, and we have people that are growing their for plants, and we have all of that product that is pretty much being grown to be diverted. And it's not always at the feet of the medical marijuana growers, and we really need to make sure that distinction remains uppermost in our mind, because you know, diversion happens all across the state, and it doesn't matter if you're OMP, OLCC, or ODA and hemp growers. It happens, and we have to make sure that we don't put all of that blame on the medical growers.
Okay, so how do we draw those distinctions? How do we make those definitions? And how do we accurately portray what, you know, what percentage of each origin of diversion exists?
So I think to the question of how do we accurately portray it, that's the million-dollar question that we're all trying to solve. We have, via the seed-to-sale tracking system, a very good, or at least fairly good, handle on the volume that's being produced in the recreational system and where it's going. I won't claim that there's been no diversion out of the recreational system. We know there's been diversion because we've caught people. There's diversion out of home grows, I'm sure, and there's diversion out of grows that are just purely illegal. I think the focus on the medical system is due to you know, circumstantial evidence that these are the large producers who are subject to the least amount of regulation and who have legal authority to grow substantial amounts of cannabis.
You know, I would add to that, Jesse, is that there, you know, I don't know if it's a fair characterization of the medical problem. The medical marijuana program and participants are the bulk of diversion in the state of Oregon. There are no numbers to back that up. It's all anecdotal, so I don't know if it's fair to characterize it that way. But the fact of the matter is that the medical program is regulated a lot less than the OLCC, so there are more opportunities for diversion within the medical marijuana program. I think we're going to address some of those issues related to SB 1057 with getting certain medical producers that meet a certain threshold onto tracking, but they still are exempted in rule and regulation from the same security regulations that OLCC has. So, you know, the fact of the matter is that they are regulated less, and that you know, it's up to every individual to do what they feel is right. But if you don't have those regulations in place, it opens up opportunities that wouldn't normally exist if they were a little bit more tightly regulated.
And I certainly concur that in the absence of data, it's probably more appropriate to talk about opportunity rather than assuming facts that we don't necessarily have. I'll also add, as my last point on this subject, hopefully, that should this commission have recommendations for OLCC on limiting diversion within our system, I'm sure that the OLCC would happily take those recommendations. And you know, we haven't even really talked about hemp, but hemp is another program that is regulated very, very differently than the recreational cannabis program. So it may be appropriate to talk about diversion globally and not just as it relates to OMFP.
Yes, that was really my point. Pardon me for interrupting, but that's really my point, is to make it more a global conversation than just pointing the fingers. Thank you.
Yeah, so I was trying to get back to the action steps that we can do for diversion. And I'm not really sure where to start, but I think, you know, nobody likes more regulation. I mean, it's not really, Americans just don't like it. But I think that an action step is to identify gaps in the regulation globally where there's an opportunity to address the issue of diversion.
Yeah, for instance, just one real quick, but for instance, we addressed this, OLCC just limited the amount of immature plants that a producer can have, and the OMFP program's also addressing that, so I think that's good to identify the steps that we can take to minimize it globally.
So I actually was having a proposal, because there was a lot of discussion about this. There was a lot less discussion about training, and we haven't gotten to the other two. So, but my proposal was sort of looking at the time exactly that these buckets related to training, product, access, and then a kind of research, there actually are people, back to your suggestion, Dr. Knox, about subcommittees or work groups. So it's clear that there are some people at the table who know a lot about product and diversion and testing, and some of us who don't. The training piece, it's clear that there are some people at the table who know a lot about that. And so my proposal was actually, even though we haven't gotten to the access into the research, Dr. Chu, her position is related to research, so I would volunteer her. It's always nice when people aren't present to volunteer for work. Dr. Knox, though, I would volunteer for number one. When it's product, I don't know if that's Andre or Jesse or a combination. And of course, Anthony needs to be part of the kind of work group. And the access to patients, I again, don't quite know whether that one has to do with Anthony, but setting up work groups and to really have discussions about what this group can and can't do. This really is the Cannabis Commission, and I understand, but it really is focused on medical. So I understand the diversion piece and broader, but I am concerned, or I'll just put a comment out about scope, that every group that I'm on, boards, commissions, et cetera, always have issues with scope. And trust me, people never want the scope to be smaller. They always want to have the work be sort of, fill whatever void, and so we recognize the void. Back to the specific work of this Cannabis Commission. There are two pieces. So on page one, provide advice, and I don't know exactly what these two, but both the OHA and the OLCC, so presumably that's something about administering both the program and the product. But then the two that I was focused on, the longer term plans for ensuring that it remains cannabis remains a therapeutic option, is kind of where training falls, and at least the access to patients, and research. And then the second is ensuring it's affordable. That's the access piece. So I just want to be clear. Again, my proposal was to focus on what the very specific things were and how the work that we do ties in. I know that we can't, the diversion piece can't be only specific, I heard what it was said about the medical market, so you need to look at gaps, but I'm just concerned, also, even if this commission comes up with things about diversion here, what OLCC or whatever you do to the legislature, it might be that they're all like, why is this group dealing with everything that has to do with cannabis from soup to nuts? We actually were talking about the medical program. So I just want to be clear that what we do, and again, biting off what we can chew before next session, not the one that's coming up immediately, but we just bought a little time, but we don't have all that much time to prepare whatever plans or reports or recommendations to the legislature. So I'm all for work groups.
Yeah, I agree with that wholeheartedly, and especially in the interest of time. We only have 10 minutes, so I like the idea. It sounds like everybody else agrees that it would be appropriate to start forming these subcommittees to start having more in-depth conversations about how to move forward in these buckets. I do like the comment about addressing hemp. We're overseeing medical. And hemp is real big right now for the CBD, and that's a huge medical concept and discussion happening on a global front. So I do think one of these buckets should probably address that, even though it's hemp in our state is regulated completely differently. I think that we should weigh in, at least in part and parcel, on hemp production and distribution. The subcommittee. Yeah.
I would, I'll volunteer myself to chair the subcommittee on product integrity, I guess we can call it that, on the commission that I'm joined by my colleague at OLCC. And I know that the optics of having two regulators running this important subcommittee might not be the best, but we'll try to get some input from non-regulators on the subcommittee.
Yeah, it'll always be checked and balanced by us.
Yes.
Anyway, so I think you're safe.
So I'm sure my colleague to my right will have some input on this subcommittee. The other thing I'd like to note is there is a law enforcement seat on this commission that's not yet been appointed. So when that seat is appointed, I'm assuming that individual will have something to say about this subject matter as well.
I'm happy to help in any way I can, and I would actually volunteer to be the lead on the number 3 one, the access for patients.
Yeah.
I myself am happy to take the lead over training, and there was a nomination for Dr. Chu to oversee the subcommittee on research.
Yeah, and I'd be happy to work with her on that, because that's really the area that I kind of know sort of most about, and what the gaps are and what the data show. And I do appreciate, by the way, even though I don't know much about products and diversion and all that, but I do appreciate the need for data about what's happening rather than just anecdotes. So to the extent possible, and again, I don't exactly know, I mean, you all are the ones who are tracking product, but really trying to get an idea about what the scope of that is, I think is really important.
Okay, what time is it? Almost time. Okay. So the last thing on the agenda was to discuss timeline, structure, location, and length of meetings for the rest of the year. Last meeting we talked just very briefly about the frequency of meeting. Somebody, it might have been me, had mentioned meeting more than 4 times a year. Where do you guys fall on that spectrum at this point, being it already 2018 January? First quarter closing pretty quickly.
If I might, I think if we work backwards from the deadlines for legislative proposals, pre-session filing, that's probably the way to approach it. I'm not sure of all those dates, but we have, like, usually in September, that's when stuff can be submitted by the committees to legislative council, and then by the middle of December, it's usually they're done and ready, and then introduced officially by the committees, published and all that. So we want a comprehensive something, and just as a quick aside on that, I'm not, it's always tricky to put a big comprehensive omnibus bill in there, so maybe in our overall strategy and our timelines, we figure out how to kind of split it up and put one into the healthcare committee and one into, or however our strategy works, but I think working backwards from those deadlines would probably serve as well.
Okay, so we need to identify those dates.
So I would agree with that, and I think the second thing is even, and I'm not saying that we're going to do this, but even if we were to only meet 4 times a year, there's a lot of work that the subgroups have to do. So at least I wouldn't feel like even if this group didn't meet for 2 or 3 months, that didn't mean that work wasn't happening. In fact, there might be quite a bit that's happening, and then what we need to do is to bring it back and have some discussions about the findings of the work group at a bigger meeting. So it may actually be whether it's quarterly or even a little less, that doesn't mean that the work isn't happening.
I would agree that subcommittees could meet intermittently between the larger commission meeting. They are still probably subject to public records law, so they will have to be public meetings, even though they're subcommittee meetings. They have to be noticed appropriately and all that legal stuff.
So should the frequency of the subcommittee meetings, should that be subject to the chair of those subcommittees?
Yeah, I think that's fine. I wouldn't make it more than once every 2 months, bi-monthly. I mean, that kind of sets. You get 2 subcommittee meetings in between each commission meeting. I know Jesse's a busy guy, so.
You can phone it in, man.
I think we have a lot of very busy people on this commission, including practicing physicians. So, I personally would be open to meeting as frequently as monthly as a larger body if we have the material to be productive. But I know we all have very busy schedules, so while I think monthly meetings for this entire body would be great, I don't want to get together just to meet.
And we'd have to meet quorum each time anyways, so. I'm not speaking for Esther. I think we should be as audacious as we can be to accomplish our collective goals. I mean, we have major tasks in front of us, and I believe they can be accomplished. So it may be the wrong expectation to set 4 quarterly meetings. So, I mean, if you guys want to start off aggressive, meeting once a month, bi-monthly, I think we absolutely should, especially in this first year.
When I originally proposed it, it was monthly meetings. I'm frankly okay with quarterly meetings every 3 months. I think, though, that we should consider a meeting towards the end of February or very first part of March while the session is still in, and then take it from there. Because we'll have more information available on the bills that are coming through, and that's information we can use. But I really think that the people that are in charge of their subcommittees and work groups are really going to be doing the majority of the work, and we come back every 2 or 3 months, it'd be plenty for the full body.
Couple things. So you talked about a listening tour.
Yes, I was going to get to that. Yeah.
Okay, because that would be time, and you can actually possibly have a meeting right there. You can have one day for one, one for the other. The other is on legislative concepts. I just want to kind of umbrella this within Oregon Health Authority as far as any concept. I think we need to probably run through our process. I don't know if we want to have Holly Hyber come and speak to the group. I don't know. It's just a question.
So the question on legislative concepts is kind of interesting. We have agency reps here, and we may, as a commission, ultimately propose something that the agency reps are not okay with. In that case, I think the process is Andre or I would just vote no. I don't know if there's like a separate process about running it through OHA to go through the legislative process, although it may be helpful to have kind of some legislative orientation from legislative staff. And I saw Shannon shaking her head, so maybe I've got it all wrong.
Shannon O'Fallon with DOJ. I mean, I don't think you have it wrong, but I think, right, the Cannabis Commission sits inside the Oregon Health Authority, so to the same extent that any program or section within the Oregon Health Authority that brings a legislative concept forward has to go through that process, you know, including DAS processes, and, you know, I think that all of that is going to apply to whatever the commission wants to put forward, I think.
So, okay, we're getting down into the weeds. So do you think we need to run this, because OHA is an executive branch, that this gets run through governor's office, or do you think that our independent statutory grant shortcuts that? And you don't have to answer right now.
Yeah, I mean, it's a good question. I mean, I think that it's a good question, but it could be the former. Yeah.
I just want to be proactive, so I would hate for anything to get stalled because we didn't jump through the right hoop. So that's all.
Okay, and we are just out of time, but I did want people's input on the listening tour. Really to gauge everyone's interest, capacity, availability to do so. I wouldn't expect every single one of us to be able to participate in every single listening event. But I did want to hear from you all with respect to your interest in participating and the frequency in which you could.
I would be happy to participate in some capacity. I don't know if all the members are going to be able to make every single location or meeting. I don't know if we should have that expectation that they should. And then my second caveat is that we start the listening tour after session, because things are really busy right now for state government. And it's a short session, so. And the weather will be nicer.
Yeah, we don't want to make that drive over, man.
Shannon will take that long to work.
Okay, so I suppose it will take us developing a calendar, right? Identifying the counties, the cities that we want to visit, places where we can get the most bang for our travels, of course, but we can identify that at another meeting. All right. So what time is it? 3:02. And go ahead.
When do we have our next meeting?
Yeah. So the recommendation was to be end of February, early March.
How about after March 10th?
Session closes.
Oh, you
closes
want it
when?
during session?
Well, I was just thinking that that would be appropriate, because if there's any kerfuffles around any of the legislation, cannabis related, maybe we need to meet while they're still in session.
We could call a meeting.
But
We could call a meeting if we ever felt that we needed.
that's true, that's true. And March would be the next quarterly meeting. So I think that's okay. We don't necessarily need to during session.
Okay. So we're looking more towards the end of March?
I'll have Shannon send out a doodle.
Okay. So March. All right, any last thoughts, comments? All right, and I would like to close